Okay, so this recording is about drug interactions, adverse reactions, and drugs across the lifespan. Now it's going to be a very basic type of overview, and you can see here there's 6 different chapters. It covers 6 different chapters, but what I want you to do is basically look to the PowerPoint and the recorded lecture to determine how much detail is needed for you to actually know and remember. So the first thing that we're going to do is we're going to look at drug-drug interactions. So this happens mainly in the elderly, where they have to take drugs for a lot of different conditions. So for example, for high blood pressure, for hyperlipidemia, for diabetes, for whatever else they have, and it's all sort of piled on top of another. And what happens is the drugs can actually interact with each other. And there are 3 basic different kind of interactions when you have 2 or more drugs that are taken by the same person. First of all is that the effects can be increased, the effects can be decreased, or in the third category, the effects can be totally different. So that's what we call creation of a unique response. Right? So we'll go through each of them together. In terms of the drug-drug interactions increasing, what happens is it can either increase the therapeutic effects, or it can actually increase the adverse effects. All right, and you can appreciate that when the drug-drug interactions lead to a decrease in something, again it's the same thing. So it can either decrease the therapeutic effect, or it can decrease the adverse effects. So what we're going to do is we're going to look at examples of each of these. So an example where 2 drugs taken together by the same person can increase the therapeutic effects is if a person takes 2 antibiotics together. So if a person is taking ampicillin and sulbactam, which are both antibiotics, both of them actually increase the therapeutic effects. In terms of 2 drugs that increase their adverse effects, so if a person is taking aspirin and they're also on heparin, you know that it increased the chance of a hemorrhage occurring, which is definitely an adverse effect. In terms of 2 drugs interacting which lead to a decreased therapeutic effect, we see this effect very often with a woman who's taking birth control medication and who is on antibiotics, say like penicillin, and you know that when a person is actually on birth control and takes penicillin, the effects of the birth control, the therapeutic effects, are very, very much lessened. And then the effect of 2 drugs that decrease the adverse effects are morphine. So if you have a person coming in with a morphine overdose, what happens is that that person may be given naloxone or naltrexone, which is works in the same way. And what naloxone and naltrexone do is they inhibit the effects of the morphine, the adverse effects of the morphine. So they actually stop the overdose from happening. Now, the third category, creation of a unique response, is what happens with people who are on disulfiram. And disulfiram is antabuse, so it's given for to people who want to stop their intake of alcohol. And what happens is if a person actually has disulfiram, it doesn't actually do anything to that person. But if that person actually ingests any form of alcohol, what happens is it makes that person throw up and vomit, nausea and vomit. Right? So it causes severe nausea and vomiting in the presence of a second drug, alcohol. But in and of itself, disulfiram doesn't do anything. And if you have a person drinking alcohol without actually having disulfiram, then they won't normally throw up and have severe nausea at sort of non-intoxication doses. But the combination of the two leads to creation of a unique response, which is severe nausea and vomiting. All right, so how does the drug-drug interactions work? What's the basic mechanisms of those interactions? Well, there are 4 different types of interactions here. So what you see here, the categories are direct chemical physical interactions. Second one is pharmacodynamic interactions. Third one is pharmacokinetic interactions. And then the fourth one is combined toxicity. So we'll go through each of those. So what happens is if you combine 2 drugs together in the same solution, they can have direct physical or chemical interactions. So basically, the rule of thumb is never combine 2 more drugs in the same solution, because that might happen. Right? So what might happen is that it might cause one of the drugs to come out of solution and therefore not be soluble and do its work, or there might be a direct chemical interaction which would negate the effect of one drug or enhance the effect of a drug. The second thing is that you can have pharmacodynamic interactions, and this is what happens in the last example with morphine and naloxone. So what happened is those 2 interact at the same receptor, which is the mu opioid receptor. And what happens is morphine activates the receptor, naloxone blocks it. So if you have both morphine and naloxone together in the same person, what happens is they cancel each other out. All right, so the combination of those 2 are basically end up being inhibitory because they cancel each other out. The other thing that can happen in terms of pharmacodynamics is that they can interact at different receptors. Right, and I won't give you an example of that, but say if you have 2 different drugs, they actually act on different receptors, and they actually interact and either enhance or decrease the pharmacological effects. Now, the third category of groups are pharmacokinetic interactions, and you know pharmacokinetic is divided into 4 different things. First one is absorption. Second one is distribution. Third one is metabolism. And then fourth one is elimination. All right, so the interactions can occur at any of these 4 points. So for example, you can have 2 drugs which, if administered at the same time, will actually affect absorption. And sometimes you want that to happen. So an example of this is if you give a local anesthetic, say xylocaine, and sometimes that's administered together with a dose of epinephrine, and what happens is the epinephrine constricts the blood vessels at that point that the xylocaine is given, so that the xylocaine doesn't rush through the systemic blood supply as quickly, so it stays within that local area and numbs that local area. And also then a lower dose can be given because the xylocaine just basically stays in that local area and numbs that local area for a longer time. So epinephrine is actually given to actually constrict the blood vessels so that you give a lower dose and then it doesn't actually enter into the systemic circulation. Because you can imagine if you give someone xylocaine and enough xylocaine to actually enter into the systemic circulation, what happens is it actually will inhibit all nerve firing throughout the system, because it's basically like giving them a instead of a local anesthetic, giving them a general anesthetic. Second one is altered distribution. So what happens here is that two drugs can compete for protein binding. So for example, if a person is taking both warfarin and phenytoin, which is Dilantin, what happens is both those drugs are highly protein bound, and they can compete for that protein binding together, and therefore change the amount of free drug. And if you change the amount of free drug, you change the amount of drugs that's available. And you can actually increase the therapeutic effects of one unknowingly. Altered metabolism. What happens is some drugs basically change the level of liver enzymes that basically metabolize drugs. So you can have, if you have a drug A, that it increases the level of liver enzymes, and that person is taking drug B, what happens is drug B can be metabolized a lot quicker because the level of liver enzymes increase. And so if drug B is metabolized more quicker, then you have less active drug B, right? So that affects how much drug B is effective. And then the last one, altered elimination. So basically what happens is that some drugs can change the level of pH or can change the level of filtration or absorption, reabsorption, or excretion, and therefore change how much drug is being eliminated. So if you have drug A increases elimination, right, it speeds up the renal excretion process, then what happens is if that person actually takes a second drug, that second drug gets eliminated a lot quicker, and so the therapeutic effects of the second drug doesn't last as long. And then the final mechanism is combined toxicity. So basically the two organs, or the organ that's most likely to be affected by toxicity, is the liver. So you have drugs that are hepatotoxic. And then you have some drugs that are neurotoxic, some drugs that are toxic to the kidney, renotoxic, and so on and so forth. So the accepted wisdom is if a person is taking multiple drugs, you shouldn't give two drugs that are both hepatotoxic, because that increases the chances of permanent liver damage. Alright, next one is drug-food interaction. So again, what we have here is we have the mechanisms of drug-food interactions, and you can see here that the first two are really pharmacokinetic interactions. The last one is pharmacodynamic. Alright, so let's start from the top. So drug absorption, what happens is both the rate or the extent can be influenced. So what happens is sometimes a food can actually decrease the extent of absorption so that less gets absorbed. And when you have less of the drug being absorbed, then it decreases the therapeutic effect. Or sometimes you can have, you can take food, a patient can eat food that decreases the rate of absorption. And what happens when the rate of absorption is decreased? It basically just takes longer, so it's slower for the effects to be met. So slower onset of effects. And then sometimes what you have is you have some foods that actually increase the extent of absorption. So you have some drugs that increase the extent of absorption. This is definitely true in some HIV drugs. And so what happens is if a patient is being prescribed some HIV medication, then if you encourage that patient to actually take some high caloric meals, then that increases the extent of absorption. All right, and if you increase the extent of absorption, that increases the therapeutic effect of the drug. All right, in terms of drug metabolism, the big culprit here is grape juice. Grapefruit, sorry. What happens, and it can be either grapefruit, the fruit, or grapefruit juice. What happens is something in grapefruit basically decrease the metabolism rate of some liver enzymes. So what happens is that the liver enzyme levels drop, and so the amount of drug that stays in the system increases for longer. So what happens is if you don't actually educate the patient and they're eating grapefruit every morning for breakfast, what happens is it basically slows down the metabolism of drugs, and then the drugs build up, and it build up to such a level that it can reach toxic levels. Okay? Now, third one, in terms of drug toxicity, a famous one or a common one is if a person is taking MAO, monoamine oxidase inhibitors, and that person is eating food products that contain this thing called tyramine. And tyramine is found in aged cheeses, in processed meats, in chocolate, in fava beans, in quite a lot of different foods. And what happens is that the MAO inhibitor basically works so that it allows tyramine to be converted to norepinephrine. So what happens is if you have an increase of norepinephrine, is that you have an increase of cardiovascular toxicity effects, right? And you have an increase in heart rate, increase in cardiovascular, heart contraction, increase in stroke volume, and then it leads to cardiovascular events. Now, in terms of drug action, the last one, this is quite common in people who are taking warfarin. Now, the way that warfarin works is it inhibits those clotting factors that contain vitamin K. So if a person is on warfarin and eats vitamin K rich foods like broccoli, what happens is it will actually decrease the effects of warfarin, because the vitamin K rich food allows more vitamin K containing clotting factors to be made, and that sort of undermines the effects of warfarin. Another possible drug food interactions in terms of drug action is theophylline, which is sometimes used as an asthma medication, and caffeine, because caffeine also does the same thing as theophylline, so it actually interacts with theophylline to lead to increased CNS excitation. Alright, so moving on. So, how do you minimize adverse interactions? It's all here. Take a thorough drug history, and that includes herbal preps. That also includes, as we saw, foods, right? Especially if you're educating a person, a client, about the drugs that they're taking, to actually educate them about what drug-food interactions might be possible. Educating the patient about the timing of drug administration, so taking on an empty stomach means 1 hour before a meal or 2 hours after. So what happens when taking a drug with a meal reduces stomach upset but also reduces drug absorption? Well, then you have to actually educate the client to say that the important thing with the client being prescribed a drug is that the drug actually works. And if at all possible, if they can actually put up with the stomach discomfort so that the drug can actually work, that's a better gain than not having an upset stomach. As I said before, conventional drugs can interact with herbal preps, so just being aware of what some of the herbal drugs or herbal preparations actually do. So there's an example there. So some people take St. John's wort as an antidepressant, but it also basically induces some liver enzymes, which means that if they take drugs, it actually metabolizes those drugs a lot quicker, and so those drugs don't have time to actually have an effect. So just being able to educate the patient that that's true. Alright, adverse reactions and medication errors. So basically, a definition of an ADR, adverse drug reaction, is a noxious, unintended, and undesired effect that occurs at normal drug doses, right? Who's at risk? Very young, very old, very ill, those taking multiple drugs. And these are all very obvious groups, right? So very young, undeveloped organs. Very old, you've got a lot of wear and tear on the organs, so the organs aren't actually performing at optimum speed. Very ill, again, you've got compromised organs and immune system. And then those taking multiple drugs, as we saw before, you can have people that are taking multiple drugs have an increased risk of having drug-drug interaction. Types of adverse drug reactions, they're listed here, right? So idiosyncratic, usually based on genetic predisposition. Carcinogenic effects, sometimes what happens is that it's really hard to pinpoint, because a drug may cause cancer, but it doesn't cause cancer in a month. So it may cause cancer 5, 10, 20, 25 years down the road, and then it's hard to actually backtrack and see that the cause of the cancer is because of a certain drug. Teratogenic effects are drugs that induce birth defect, and this is really, really hard to actually control, because it's hard to test for, right? You can imagine that really no pregnant woman's gonna come forth and say, sure, I want to be tested to make sure that this new drug on the market doesn't cause birth defects. So a lot of these studies, or a lot of these findings for teratogenesis, actually occur as women are being given the drugs while they're pregnant. So a famous case is thalidomide. So in the 60s, there were a whole bunch of pregnant women who suffered from morning sickness. They were given thalidomide off-label in the States to actually alleviate their morning sickness, and it did do that, but then it ended up with a lot of them ended up with babies with shortened limbs, right? So that's where the thalidomide babies came from, and that was a direct effect of taking thalidomide. So they've worked it out that it could be traced back to that drug. Allergic reactions. So most drugs can cause allergic reactions in a very, very small subpopulation of the general population. So what happens is it's just hypersensitivity of the immune system, and it's not dependent on the dose of the drug. Hepatotoxicity. So this is damage to the liver, which can be permanent as well. So this is one of the most common reasons for removing drugs from the market. And again, unfortunately, when a drug undergoes testing, most times the drugs are only tested on a group of people, whether they be healthy individuals or patients. They're only tested on a group of people for not very long, right? For 2 years maximum. And again, sometimes a drug is hepatotoxic if a person takes it for 5, 8, 10, 15 years. And so they don't have that data, the drug company doesn't have that data when it actually goes through FDA approval or Health Canada approval. Some drugs widen the QT interval in the heart rate. So again, it can cause dysrhythmias and really cause a whole lot of cardiovascular complications. All right, so what do you do with medication errors? Medication errors are a major cause of morbidity and mortality, and it's up to every member of the healthcare team to make sure that there's no med errors being made. Unfortunately, you as the nurse, you're the last line of defense to prevent a med error from occurring, and so good to double check at least, right? Double, triple, quadruple check before the medication is being administered. 3 of the most common errors involve human factors. So the first one is knowledge deficit. So if someone on the healthcare team doesn't know the full facts about the drugs and how it can actually interact with other drugs, how it actually what it actually is used for, and how it will affect the patient, either therapeutically or not. That's a common error. Another one is miscommunication, the infamous doctor's writing not being legible. And then sometimes drugs have similar names. Confusion of drugs with similar names. So quinine versus quinidine, and Lasix versus Losec, right? So Lasix is a diuretic, Losec is a proton pump inhibitor. Very, very different. Very different effects, very different indicators, and very different drugs. But the names are very, very similar, especially if they're spoken out loud in a rush kind of situation. Medication errors have to be reported. These incident reports are not meant to be punitive in nature. So there's some ways that are good to prevent errors. So they're listed here. And in a lot of hospitals or healthcare settings, these steps are already in place. All right, so what we're going to do now is we're going to look at the sources of individual variations. So if you have 2 people given the same drug, those people might react differently because they're different individuals. And it might be that one is a male, one is a female. It may be that one is 80 years old, one is 8 months old. It may be that, one's overweight, one's underweight. So there's a whole lot of different sources of variations. Okay? So we'll go through them very briefly here. So first one, body weight and composition. Obviously, smaller patients need smaller dose, but the way to actually determine how what the dose is by looking at body surface area. So that's what BSA is. And it's more accurate than just taking a gross weight of the patient. Age and gender also has an effect. So obviously, as we said before, very old or very young are most likely to be have variations in their responses to drug, because very young have immature organs, the very old have very old organs. Gender, there's also some data to suggest that men versus women respond differently to drugs, to certain drugs. All right. The very ill. So if a person has kidney disease, what happens is it can reduce elimination. So drug stays longer in the system. So what happens is it can increase the effect of the drug. So instead of being therapeutic, it can actually build up so much that it becomes toxic. Liver disease, same thing. So if a person has liver disease, it decreases metabolism. So the drug can stay longer in its unchanged active form, and it can actually increase the effect. Right? So suggestion with both these things is to actually reduce the dose of the drug to actually account for those changes. Another source of variation, tolerance. So you know what tolerance is, where you have a decreased responsiveness to a drug as a result of repeated drug administration. So that occurs with barbiturates, that occurs with opioid narcotic drugs. So what happens is that person has to take an increased amount of drug to actually have the same effect. So you can have both pharmacodynamic tolerance, and what happens with that is it increases the minimum effective concentration. So the start of the therapeutic levels is actually increased. Instead of say a person getting therapeutic relief at 10 mg, they only get therapeutic relief at 20 mg, right? So that's an increase in the pharmacodynamic tolerance. The other one is pharmacokinetic tolerance, and this is usually metabolic. So what happens is that the enzyme levels increase. So what happens is you have to increase the dose to get same effects. Okay? Next one, placebo effect. You all know what a placebo is. And then the one after that, variability in absorption rates. So what happens here is that this is very important, especially with drugs with a narrow therapeutic index. So you remember therapeutic index is the difference between a therapeutic versus toxic dose, and some drugs, their therapeutic and toxic doses are very, very close to each other. So you have a variation in absorption rate. It can easily get to the toxic levels. Genetic factors can involve changes in metabolism. Race has more to do with genetics, because people of similar races have a more similar genetic pool. And number 9 is patient compliance. So really, patient compliance is the number one factor in why a drug does not work. Because usually a patient decides that the drug's too expensive, they don't want to take that much drug, they forget, they lose the drug, they for some reason they don't actually take the drug as prescribed, and then lo and behold the drug doesn't work because they don't take the drug. All right, so that's one of the big things. And then drug interaction we covered before, and diet as well we covered before. All right, so drug-food interactions. So you've got some multiple choice questions happening here.